Hello, and welcome to another episode of You and Me and Multiple Sclerosis. My name is Pam, and I've been living with multiple sclerosis for 38 years. I really appreciate those of you who asked after me and wished me well for getting over this yuck that I've been dealing with in the past few weeks. And I will tell you that I don't have any more symptoms of anything except I still feel like there's only a limited amount of energy that I have to spend, and it's even more limited than it had been up until January 1st. So I don't know how long that'll go on, but it's MS, so there's no predicting. Thank you anyway for wishing me well. Well, just this morning, I got a posting from Dr. Gavin Giovanni, who also goes by Professor G, by the way, so I think that's what we'll call him in this video. He had made a presentation recently about MS and the state of treatment from his perspective. And it was about an hour long. I watched the whole thing, and maybe eventually I'll cover other parts of it. But today there's a certain part or certain aspect of it that I wanted to go over a little bit. And that had to do with his idea that we can't just look at MS as MS and not look at the whole rest of the body and what's going on and what's best for the body, because we are a whole system. We're not just MS, right? We have a lot else going on. And it does seem that over the decades since medicine really got going, specialization seems to be the order of the day. And the more a doctor learns about a very specific field of study, the less he may know or she may know about all the rest of medicine. That can be a problem, right? Here's what Professor G had to say. He starts out talking about remyelination, which I think you'll agree is kind of the holy grail of MS treatment. If we could regrow the nerves that are damaged and even the nerves that we've lost, we might be able to really reverse the disease. And much work has been done on that. But let me go ahead and start out by having you see what Professor G has to say about the state of remyelination research and trials.
Remyelination has been disappointing. We've had some really high-profile failures over the last 4 or 5 years. High-dose biotin was meant to work by promoting remyelination and also helping mitochondrial function. There was improving energy consumption. Bexarotene also failed. We think that may have failed because of trial design. And when you look at the data, it looks like younger patients did benefit. And then the two antibodies, opicinumab and elezunumab, both of these bind to inhibitors of remyelination, also failed. Now, I don't think the biology is wrong. I mean, when you look at the biology of these compounds in cell culture, in animal models, they work. There's no doubt they work. I think our mistake is we haven't included in our remyelination neurorestorative trials active add-on rehabilitation or exercise. And the reason I say this is the mechanisms that drive recovery of function, and this is remodeling of axons, sprouting of axons to create new connections, synaptogenesis, the actual synapses between axons and nerve cell bodies, and then obviously the plasticity mechanisms that the brain uses to recover function. All of these require a physiological stimulus, and the best stimulus is rehabilitation or exercise. And we haven't added into our trials rehab, or we just rely on spontaneous recovery of function. I think this is the mistake we're making. If you're speaking to a person working in stroke medicine or somebody working in spinal cord injury, they would never, ever design a trial without having rehabilitation embedded into it. And I think we're going to have to go back to the drawing board and reassess whether these drug trials fail because of biology or trial design. And I think it's trial design. And I think every single remyelination neurorestoration trial should include targeted rehabilitation to try and create the signal for recovery of function. Some of my colleagues disagree with me. They think this will happen spontaneously. I don't. Why would you? I mean, it's like somebody who has a relapse and they don't use that hand, that hand's not going to recover. They have to do rehab to train that hand to recover. And obviously, if you're on a drug that makes that recovery quicker and better, then you're going to see the difference between placebo and active treatment, because the drug, in combination with rehabilitation, will result in improvement in function.
But now Dr. G goes on to say something that I think is really interesting, and I wish more doctors thought his way.
And then the other thing I said to them in the future is, we're missing a trick. We got to just stop thinking with our blinkers about MS, but also think about what I call the non-MS targets, the brain health targets. And I've written and spoken on MS Selfie about this endlessly. You know, we've got to promote brain health. And this is the kind of messages we're trying to get across to the general population. You know, you should not smoke, you should drink alcohol in moderation, exercise, and I personally think HIIT's better than aerobic. Obviously, make sure your diet is good, and there are some diets that are better than others in terms of promoting brain health. Sleep hygiene, we know that people who don't sleep very well do worse. Comorbidities, infections, we've got to stop all these or try and prevent these. Concomitant medications, we know anticholinergics are not good for the brain. We should probably try and optimize people's medications, get off anticholinergics. Anti-aging medications, HRT, metformin has been used now or tested as anti-aging, and we should watch the space. Maybe in the future, everybody with MS will need to be on metformin. And then social determinants of health, this is really important. So we now know, particularly during COVID, that people with poor social determinants of health did badly. And in MS, we know it's a big problem. People are socially isolated. They are lonely, and we know loneliness kills. And we shouldn't just accept this. There are things we could do to promote social determinants. In other words, improve people's ability to get out, connect, etc. And then obviously wellness is just more than health. It's focusing on other things, how you interact with the environment, spirituality, etc. So there's lots that can be done in terms of non-MS targets. And I always talk about marginal gains. You know, if you improve a lot of things by small amounts, they all add up and result in a much better outcome. So, the future of MS is not just about treating MS, but also about promoting brain health. And I put this up as just an example. This is a small study published 2 years ago from Germany, comparing moderate continuous training versus high intensity interval training, or HIIT. And looking at just the red box here, this is neurofilament levels. You can see people who went on to HIIT had a much greater reduction in the neurofilament levels than people who had moderate continuous training. And there's other data outside of MS showing you that HIIT is better than aerobic continuous training. Now, HIIT is hard. You've got to get onto a bicycle or treadmill or do whatever you can do. And you've got to get your heart rate up to above 90%, probably for several minutes in a 15-minute cycle. And it's tough. It's painful. Whereas moderate continuous training, your heart rate is really between 60 to 80% of your predicted maximum. And there is little doubt that when you look at peripheral biomarkers, HIIT's better than moderate continuous training. And I suspect this will pan out in MS as well. We want to do a trial of this to see what the biology is on the central nervous system. But and don't feel you can't do HIIT. Even people in wheelchairs can do HIIT using upper limb exercise. So if you are going to choose an exercise strategy, I would suggest you look into HIIT. Another thing that's come out is, and this is work by Robin Franklin's group in Cambridge, is that people who are older don't remyelinate or recover function very well. In other words, their cells become senescent or age. And that you can actually rejuvenate those cells and make them young again by actually adding on metformin or fasting these people. I think why this happens is that there's this particular biological pathway called NRF2, which is a programmed cell survival pathway. And there are lots of things that activate NRF2. It's not only caloric restriction. We know intermittent fasting and ketogenic diets do it. Some nutraceuticals can do it as well. And drugs like metformin. And I put here fumarates because fumarates actually bind to a receptor that activates NRF2. And exercise has also been shown to do it. So there are a large number of things that can be done to hopefully rejuvenate remyelination recovery functions. And it's not just metformin or fasting, lots of things that can be done. And I won't go through these pathways in detail, but all I want to point out that there are well-defined metabolic and biological pathways of how these different strategies work. And this is not unique to MS. This is probably a principle for other neurodegenerative diseases as well. And I want to point out that when you do go on to prolonged fasting or you go onto ketogenic diets, your body changes its metabolism and it produces these things called ketone bodies. And one of the ketone bodies called beta-hydroxybutyrate, which goes up highest, is actually a bioactive compound. It binds to a receptor on cells, which is exactly the same receptor that fumarate binds to. And it activates NRF2. So I actually think ketogenic diets or anything that puts up your ketones, be it fasting or caloric restriction, is activating NRF2, and this is promoting rejuvenation and anti-aging mechanisms and recovery of function. So this is possibly why people are, and there are some early reports of people doing well when they do dietary manipulation to put up ketones. And there was a hint. So I was actually on the steering committee, so this is a conflict of interest, but we know the Affinity trial of opsumumab, which is a monoclonal antibody that blocks a drug called Lingo, which is an inhibitor of remyelination. When we did the trial was sadly negative, but this was an add-on trial. So this is one of the future strategies where you have a baseline anti-inflammatory and you add on treatments on top. And the trial allowed people to be on interferon beta, dimethyl fumarate, or natalizumab. But you can see when in the dimethyl fumarate group that it looks like the people did better with opsumumab. In other words, there is a gap between the placebo and the active treatment arms, where there is no gap with interferon beta and natalizumab. And the reason why I highlight this is dimethyl fumarate, increases NRF2, which may promote recovery of function. So I don't think we should ignore this. This is just a signal in the trial. And maybe in the future, dimethyl fumarate may be the fumarates may be the drugs of choice to add on remyelination therapy strategies. Anyway, what's happening in the UK is instead of DMF, they're going to be using metformin, which also increases that survival factor, as a base to add on a pro-remyelinating agent, and the drug is clemastine in the Cambridge Edinburgh trial. Another trick is comorbidities. So this is actually data from Canada, just showing you that if you have MS and you have any vascular comorbidity, be it smoking, high blood pressure, diabetes, high cholesterol, dyslipidemia, or even blockage of arteries, peripheral vascular disease, or cardiovascular disease, you get to using a walking stick about 6 years earlier than people without vascular comorbidities. And there's no doubt vascular disease is bad for the brain. And I suspect what's happening here, this is reducing reserve. And this treatment gap, this disability gap of 6 years is enormous. This is bigger than the treatment effect of interferons, for example. So we're missing a trick by not managing MS holistically. We should be aggressively screening, treating, or even preventing people from getting vascular comorbidities. So this is population health, essentially. Okay, and this may be why the drug simvastatin is the first statin that came out. This is a drug to lower cholesterol levels. And Jeremy Chataway, a colleague of mine from Queen Square in London, did this phase 2 trial showing you that high-dose simvastatin, that's 80 milligrams. Okay, people who took it with second progressive disease had reduced brain volume loss in the first and second year and across the whole 2 years. And because of this, there's now a phase 3 trial called MSStat2 running with the idea of trying to confirm this. And if it does confirm, I see people with progressive disease or more advanced disease going on to a statin in addition to an anti-inflammatory therapy. So this is the future. And I just want to say that we have to, as an MS community, manage MS holistically. You know, a lot of us are siloed. We just look after disease-modifying therapies and we don't think beyond that. And I think if we want to make a difference to people with multiple sclerosis, we have to look at them holistically. And that means developing our services. You know, our services are not ideally suited for infection prevention. We're not screening and managing sleep problems aggressively enough. We are prescribing anticholinergics rather than getting rid of anticholinergics. We need to promote HRT in women who are going into the menopause. We need to have programs to address social determinants of health. If we've got a patient who's lonely, we need to stick them into a social prescribing program where they may get a link worker helping them do community-based projects, be it gardening, art classes, book clubs, etc. And it's not those activities necessarily, but it's meeting other people. The brain is a social brain and we need interactions. So there are lots of things we can do beyond just treating MS with disease-modifying therapies. And I think this is, it may not be exciting, it may sound very boring, but you speak to anybody with multiple sclerosis or speak to anybody who runs MS services, we just don't have the resources in the NHS to do this at a scale. We're so overworked with just managing disease-modifying treatments, managing diagnosis and symptomatic problems. Trying to manage brain health is a task, and we're going to have to be innovative how we do this. And this is one of the reasons why I've started MS Selfie for MS Self-Management, is to try and promote this concept of brain health.
So given that what Professor G is saying, that there's no way that MS doctors can possibly stretch themselves to cover every aspect of a person's health, well, that makes sense. And as I said earlier, the specialization tendencies means that we have a lot of doctors who know a lot about very specific things, but they're not equally expert in all fields. So what we might need to do is think about how we, as individuals with multiple sclerosis, can take charge of our health, and part of that is putting together our own medical team. Now, we may be limited by geography or by the type of insurance we have, various other things. But as much as we can, let's look for people to be on our medical team that will fill in some of those gaps. For example, I have already at Oregon Health Sciences University, I have a neurologist, I have an oncologist, I have people who do the diagnostic stuff, but I also have here locally in town a primary care doctor and a physical therapy group. And those folks can be very important members of my medical team. I've used them over the years to good effect because each one can diagnose or treat or check for various conditions that perhaps the others don't specialize in. It's made a big difference, and given Professor G's remarks, I'm thinking I'm going to look into this even more, and maybe even discuss it with my neurologist about who all should be on my team, even if it means I'm the one that has to arrange for the appointments, etc. It would probably be worth my while to start treating myself like a whole person, and not just with a person who has MS, as if that were in some kind of vacuum, separate from everything else in my body. I don't know. What do you think of that idea? Is that something that makes sense to you? I would love to know, so please leave me a comment. And that is really all I have for you today. I don't really have a ton of stamina, so this isn't going to be a very long video. But I do appreciate being back talking with you again. So take really good care of yourself, and I will see you again in my next video.